A single acetaminophen tablet costs a hospital roughly 2 cents. The same pill handed to you in a paper cup during a routine hospital stay appears on your bill for $47. That is a markup of more than 2,000%. And the hospital did not even manufacture it. Here is how that number is possible, and who is collecting the difference. Start with the factory. Generic acetaminophen is produced in bulk, mostly overseas, at a cost so low that a bottle of 500 tablets retails at your corner pharmacy for under $4. The math is not complicated. The pill itself is essentially free, so the $47 charge has almost nothing to do with the pill. It is a fee dressed up as a pill. Hospitals call this charge a unit dose dispensing fee. The idea is that a pharmacist verified the prescription, a technician pulled the medication, it was logged into a system, tracked for liability. That process has real costs, but even generous estimates put that overhead at a few dollars per dose, not 47. The rest of the number is not cost recovery. It is margin, buried inside a line item you will never think to question. And here is where the system gets deliberately complicated. Hospitals publish what is called a Chargemaster, an internal price list that can run to tens of thousands of line items. The Chargemaster price is almost never what anyone actually pays. Insurers negotiate it down. Medicare pays a fixed rate, but the uninsured pay it in full. The Chargemaster is the ceiling that crushes whoever has the least leverage. That is not an accident. Follow the money one step further back. Most hospitals, including large, profitable ones, operate as non-profit entities. That status exempts them from federal income tax, property tax, and sales tax. In exchange, they are supposed to provide community benefit. But independent analyses have repeatedly found that the tax breaks hospitals receive exceed what they spend on charity care. The non-profit label is doing a lot of work for a very profitable machine. Then there is the markup chain no one draws on a diagram for you. The hospital buys drugs from a wholesaler. The wholesaler bought from a manufacturer. Between the manufacturer and the wholesaler sits a little-known player called a group purchasing organization, or GPO. GPOs negotiate bulk prices on behalf of hospitals, which sounds like savings. But GPOs are paid by the manufacturers they are supposed to be negotiating against. The conflict is structural and entirely legal. The manufacturer pays the GPO a fee, sometimes called an administrative fee, worth a percentage of every sale made through the contract. So the GPO has a financial incentive to keep purchase volumes high and sometimes to keep prices high. A GPO that negotiates a drug down to nearly zero earns nearly zero in fees. The math rewards the middleman for not pushing too hard, and the hospital, focused on 1,000 other things, mostly does not push back either. Now layer the insurance negotiation on top. Your insurer does not pay the Chargemaster price. They have a contracted rate, say 60% of Chargemaster. This sounds like protection, but the contracted rate is calculated as a percentage of a number the hospital invented. If the hospital inflates the Chargemaster, the contracted rate rises with it. Insurers do not always fight this hard because higher spending gives them justification to raise premiums. Higher premiums mean higher revenue. The catch is, everyone upstream benefits from the inflated number except you. For the insured patient, all of this is mostly invisible until the explanation of benefits arrives. That document lists what was charged, what the insurer paid, and what you owe, but it does not tell you what the drug actually cost, what the markup was, or whether any of those charges are contestable. The opacity is the feature, not the bug. You are meant to see a number and feel grateful it is smaller than the number above it. And the pill is just the beginning. Hospital pricing applies the same logic to saline bags, salt water, and plastic that cost less than $1 to produce and routinely appear on bills for $300. To the blood pressure cuff sleeve, billed as a medical supply. To the box of tissues. These are not rounding errors. They are a systematic application of the same markup machinery applied to every object that passes through a billable encounter. Why does this persist? Partly because hospital billing is genuinely complex. Thousands of codes, multiple payers, regulatory requirements. Complexity is expensive to administer. But complexity also creates cover. When a bill is long enough and coded in language opaque enough, most patients do not read it carefully. And disputing a medical bill requires time, persistence, and a working knowledge of a system designed by people who would rather you did not have it. There have been attempts at transparency. A federal rule that took effect in 2021 requires hospitals to publish their Chargemaster prices online. Most hospitals technically comply. The files they publish are often thousands of rows of machine-formatted data, unlabeled and effectively unreadable to any normal person. Compliance with the letter of the law and complete defiance of its spirit. The price is public. You just need a data science degree to find it. Here is what actually moves prices in this system. Not outrage, not legislation mostly, competition when it exists. In markets where 2 or 3 hospital systems have merged into one dominant network, prices are measurably higher than in markets with genuine competition. Researchers have documented price increases of 20 to 40% following major hospital mergers. The consolidation of American healthcare over the past 30 years is not just a business story. It is your bill getting larger every year with no corresponding improvement in what you receive. So what can you actually do? A few things with real teeth. First, every hospital that accepts Medicare, which is nearly all of them, is legally required to provide financial assistance to patients who cannot afford their bills. These programs are called charity care or financial assistance programs, and hospitals are not required to tell you they exist. You have to ask. Explicitly. In writing if possible. The eligibility thresholds are often higher than you would expect, sometimes covering households earning up to 4 times the federal poverty level. Second, medical bills are negotiable in a way that almost no other bill is. Hospitals routinely accept less than the stated amount, especially from uninsured or underinsured patients. If you receive a bill and pay it immediately without questioning it, you have almost certainly overpaid. Request an itemized bill, not a summary, a full itemized statement. Then go through it. Duplicate charges for services not received, and coding errors appear with striking regularity. One industry estimate puts the error rate in medical billing above 80%. Third, if a bill goes to collections, your leverage does not disappear, it shifts. Medical debt has recently been removed from credit score calculations by the major bureaus for amounts under $500, and there is ongoing regulatory pressure to go further. Collectors of medical debt often paid pennies on the dollar for your account. They have room to settle. The number that arrives in a collections letter is not a fixed reality. It is an opening position. The 2-cent pill is not a glitch. It is a precise and logical output of a system built by people who understood exactly what they were building. The Chargemaster, the GPO, the nonprofit exemption, the merger wave, the opacity of the bill, each piece fits. The system is not broken. It is working as designed for the people who designed it. Knowing that does not change the bill, but it changes what you do when the bill arrives. And that is the only move left on the board that belongs to you.